Thank you. Thank you. So, thank you very much for the introduction. Sometimes the introduction is a lot bigger than the person. So, so please don't worry. So what I'm going to try and talk about is the surgical management of facial infiltrating lipoma, and share with you some of the experience that we've had, because you have to understand that this is an ongoing journey. We're learning. We can learn from you, and you can learn from us, and we can learn from each other. But I think the most important is collaboration, is understanding. So these were the first two patients, and I have permission from all of these families. So these were the first two patients with facial infiltrating lipoma that I came across. And because of my interest in vascular lesions, and because these children had facial asymmetry, they came to see me to see that, or to see if there was anything that could be done. Now, we had a very good introduction, and we understand it was first described in 1983, and it's a disease characterized by collection of non-encapsulated mature adipocytes, which are fat cells, and that these infiltrate all of the tissues in the area, in the dermatome or in the area that is affected, and this results in overgrowth not only of the fat cells but muscle, bone, etc. So the entire segment is affected, and as was mentioned earlier, there are several of these overgrowth syndromes. Clapo, facial infiltrating lipoma, belongs to this group of conditions. And at some stage in the future, we'll be able to understand a little bit more about why some areas are affected and some areas are not affected. So they all belong to the group of overgrowth syndromes, and these are associated with this PIK3CA gene abnormality, or when something goes wrong with this gene, all sorts of things can happen. And so this group of conditions is known as PROS, which essentially is an acronym for PIK3CA related, sorry, I got related twice, overgrowth syndromes. And this is what we're going to talk about and what we're going to try and do to try and help these patients. So we understand that the mutation activates PI3K, which activates several intracellular signaling mechanisms that affect all kinds of cellular issues and results in overgrowth. And so the mutation will result in excessive proliferation and abnormal differentiation. So in medicine, we love to have these diagrams, and we think we understand a hell of a lot, but we don't, because every year we're discovering more and more. But this is the PIK3CA, which an abnormality in this gene will over-accelerate this pathway, which will lead to cellular proliferation and overgrowth. So this is essentially what we think the problem is. It starts here, and this whole pathway is activated. So what are our objectives, and what can we do? I think as physicians, our main objective is to cure the condition. At this point, we can't. And if we can't cure, then at least improve quality of life. And how do we improve quality of life? Well, in these particular cases, if we can correct facial symmetry, then we've accomplished a lot. And we should also correct skeletal distortion. So we can correct facial symmetry by dealing with soft tissue and hard tissue. In other words, the bony and dental abnormalities which need to be corrected. Now, We can correct this, but unfortunately, if we just correct it, it will recur. So is there anything we can do to prevent recurrence? So what I'd like to do is propose that we have medical treatment and we have surgical treatment. And unfortunately, in medicine, if you have a hammer, everything looks like a nail. If you're a surgeon like me, well, it's obvious. You just want to operate on everything and you can correct it. If you're a hemonc or a dermatologist, well, there's some fancy medicine that can cure this and prevent it. I think the most important is that we have to work together, because we don't have any magic bullet that can get rid of everything. But if we work together, patients, physicians, surgeons, etc., we can come up with some sort of treatment which will control this condition and improve quality of life. And that's what's important. So we have surgery, which can correct facial asymmetry. We can correct the skeletal overgrowth. We can correct some of the dental abnormalities. And then we have the, we have the various drugs which can perhaps prevent further growth or control some of the growth. So working in combination, we hopefully will be able to improve the outcome. And that's what we need to do. So the drug that's spoken about is alpelisib, and using that in combination with some sort of surgical measures to improve and restore facial symmetry is what we need to do. So I don't think mTOR inhibitors are active. Is this? Yeah, no, not at all. So that's pretty much the scheme of things. But remember, if you have a hammer, everything looks like a nail. And this is a problem, because you've spoken about the fact that doctors don't even talk to each other, and specialties don't even talk to each other. If I have, with a vascular anomaly, go to an interventional radiologist, well, then that's how I'm going to be treated. So we need to remember that as physicians, the treatment should depend on the clinical features of the lesion and not the specialty of the physician, because we need to avoid that, or the strength of the physician in charge of the group. We need to always understand that we need to treat the condition, and we should avoid the situation that if you have a hammer, everything looks like a nail. And as physicians, we need to remember that we should always be our patients' advocates, and we should not be afraid to refer the patient if we're unable to help. And so, in terms of medical treatment, the treatment that is being used or is being worked with is alpelisib, which is a PI3K inhibitor, and it works at this level. And these are some of the other drugs, but alpelisib is probably the most widely used drug. And I'm not an expert in drug therapy, but this is some of the research. We also have mTOR inhibitors, of which there is sirolimus, but sirolimus doesn't seem to be active, and alpelisib is the drug that's more widely used. As a surgeon, I have very little knowledge of these drugs. It's my hope that if I can correct facial symmetry, which I can, we can perhaps prevent further overgrowth by treating these patients with some combination of drugs. And that's what I would like to, that's the message that I'd like to get across, that we can correct facial asymmetry and by so doing improve quality of life. Now, there are two stages. There is soft tissue correction, and then there is skeletal correction, and obviously going along with that is the maxillofacial dental correction. So which comes first? Do we do the bone work first or the soft tissue work first? You have to start with soft tissue, and we have to remove the affected soft tissue and then correct the bony abnormalities that are associated. And that's always been my mantra. And I discovered this in working with patients with vascular anomalies, that soft tissue resection should come first, and we should, in this particular instance, remove all infiltrated tissue, because if we don't, there will be a recurrence. Perhaps once we know more about these drugs, perhaps we can establish facial symmetry and then use the various drugs that will come to the fore to try and prevent regrowth of the tissues. So perhaps that combination will work. But for the time being, we need to correct facial asymmetry. And my experience is in vascular anomalies and using a combination of treatment, I've been able to get rid of vascular malformations and prevent them from coming back. This is not all surgery. I can remove the vascular anomaly. I'm not going to resect everything because I can't, but with interventional radiology, with various medicines, we can prevent recurrence. So using a combination of therapies is very important. And this is her now, and I've seen her recently. This was about 15 years ago that I did the original surgery. And I have a number of these patients, and she's actually studying to become a doctor now. So she was inspired by the work that I had done. She had a lymphatic malformation, and this is a patient who came to me from Holland who also had a lymphatic malformation. So there is a lot that we can do with vascular malformations, so why not with facial infiltrating lipoma? We start with the hard soft tissue and then we correct the bony abnormalities associated. And this is a common abnormality which we also see with facial infiltrating lipoma. Some patients have a very large tongue, and the presence of this large tongue prevents the jaw from closing. And if you look at the skeletal structure, this angle is usually about 110 degrees, but in patients with severe lymphatic malformations, it's going to be a straight line, so we have to correct that. And that's because the jaw was prevented from becoming normal. So complete removal of infiltrated tissue, I think, is important. And I think that this will reduce the risk of recurrence. And the entire segment of tissue is affected, so we start off with soft tissue and then we progress to remove bone. I know from my own experience and from the experience of others that just merely scratching the surface to try and correct facial symmetry is not going to help, because there will be a recurrence, because all of the tissues in the dermatome, in the segment, all of the tissues are infiltrated with these adipocytes. It affects bone, muscle, nerves, and soft tissue. And if we just remove the soft tissue and shave the bone to correct the symmetry, there will be a recurrence. So what we've done is we've decided to be very radical with these types of cases and remove everything that's necessary and then reanimate the face. So in other words, we're going to remove all of the tissues that could potentially recur, because at this stage I don't know if alpelisib is going to prevent a recurrence. I hope so, but I don't know for certain. But I know that if I remove all of the tissues, the likelihood of a recurrence is reduced, and then there will be facial paralysis, but we can reanimate. And we can reanimate the face very successfully. The options for reanimation, and I'm going to just run through what we do because we have lots and lots of patients who present to us with facial paralysis after having undergone some surgical misadventure or some traumatic procedure, and we are able to reanimate the face, to get it moving again. And we do so by either bringing new muscle or using local muscles to reanimate the face. And the preferred method is to take a slip of muscle from the leg and bring it up into the face and hitch it up to either a nerve from the other side or a nerve from the local side, and this will get the face removing again. But it's all about balancing the face, balancing the eye, how much of the eye is open. And if we balance one side with the other, which we can do with surgical techniques, I think this is very, very important. So let me take you on a journey of how we reanimate the face, and this will give you an idea of what we can do. So we can do what's called a cross-face sural nerve reanimation, and it starts off by harvesting a small nerve from the leg called a sural nerve, and here we are using a scope, and we're following the nerve. There's the nerve, and we make a little incision and we tunnel up, and the nerve's not important because it provides sensation to the top of the foot, and you can do without it. It's not going to cause any major problem. So here is the sural nerve, and we harvest it, and we take this nerve, we take a fairly long length of the nerve, there it is, and we use it to take signal from the other side of the face. So in other words, if this is abnormal and this has no movement, we take this nerve, we plug it into the normal side, and then we run it across the under these tissues of the lip to the abnormal side, and we leave the nerve there. So what we have to do is we have to go to the normal side and choose a set of nerves that we can use that are good smile nerves, because remember, the brain sends the signal to the nerves, and you want nerves that provide just a good smile, not closing the eye or anything like that. So we select, and here we are looking for a good smile nerve, and you see we're stimulating, and you'll see you see what's happening there, some movement. And I'll stimulate again a different nerve, and yeah, there we go, a stronger smile, so that's a good one. And this is the normal side, that's a very strong smile. Okay, so we've got all of the nerves exposed on the normal side, and we're choosing what we think is the best smile nerve. Okay, and once we have that, we take this little nerve that we've taken, plug it into that nerve, and run it across to the other side. Because we know that if we've done this, that the nerves will grow in 99% of cases, will grow in along this nerve to the abnormal or paralyzed side. Okay? And once the nerve has started growing in, there's something called a Tinel sign. If you tap the nerve, they will feel sensation where you grafted the nerve. And once that's positive, we know that nerve fibers have grown in. And then we can, 6 months later, because it takes that long, we can take a slip of what we call Gracilis muscle. It's not, we don't take the entire muscle, just a little bit of the muscle with its nerve, artery, and vein. And then we transpose that and we bring it into the face, and we connect it to the side of the mouth and to the bone of the cheek, and we place the nerve there. And we can either connect the nerve from this muscle to the opposite side, or in fact we usually do that, and then if there are any facial nerves in this vicinity that are working, we can actually plug them in as well, and we can take what's called the nerve to the masseter. In other words, there are 3 or 4 possibilities that we use, and with this we can get the face to function. And I'm just going to run through this again. So those are the nerves. Now, here is the muscle that we harvest. And what we do is we slip it into two, because a natural smile will move the corner up and will also move the upper lip up. So what we do is we take this muscle and divide it into two pieces, and we hitch it up from the upper lip and the corner of the mouth to give a more natural smile. And so we want the smile to be a normal looking smile. And I'll show you some examples. All right, and there the muscle is, and I'm sorry to show these horrible pictures, but that's where the muscle is situated. And you can see we've actually isolated nerves, plugged them in, and we've connected the muscle. You know, when I show these pictures, everything looks red and it just looks like raw meat, but it's not. To a surgeon with trained eyes, we kind of know what we're looking at. And here is the gracilis muscle. I'm sorry. And there you see when I stimulate the nerve, you see contraction. So I know that that nerve is functioning, and that's typically what we do. So here is a patient with facial infiltrating lipoma. This was the first patient that I saw, and I didn't understand what it was. I thought it was a lymphatic malformation, but the pathology and the MRI were totally different. And so at that point, I knew that we were dealing with something different, and I read up about facial infiltrating lipoma and realized, and you can see if you compare the normal side to the abnormal side, you can see all of the tissues are infiltrated with fat. This layer is fat, and in a T1 signal of an MRI, the fat does not show up. It shows up as blank. And if you look on the other side, everything is infiltrated with fat, because these are the muscles. The muscles are much lighter, and they're infiltrated with the adipocytes or the fatty tissue. So we knew that this was facial infiltrating lipoma. And I did, on this particular patient, a 3-dimensional CT with reconstruction, and you can see the abnormal dentition and the infiltration of the bone. And if you compare that cheekbone to this one, you can see that there is abnormality, and so we knew exactly what we were dealing with. And some of the infiltration was way back here. So you spoke about the fact that an area has overgrown, which you didn't know about before. And I think it's always been this way. It's just that the effect or involvement of this area was perhaps less marked than the other areas. But let me get back to this particular. So you can see the abnormality and the infiltration of bone. So the first stage was a complete resection of what we could see as affected tissue. And this left the patient with paralysis. And we knew this because we were going to go ahead and reanimate her. Okay, this is before and now after. So you can see she does have movement, whereas here she does not. So you can see we've reestablished. And this was the early days before we understood to divide the muscle up into two. And so the smile is moving in that direction, but not as much in this direction. But we do have facial movement. This is before with paralysis, and this is now afterwards. Now, if you look at this child, you can see that her eye is wider on that side. We can take care of that. That's a fairly easy fix. So it's all about re-establishing facial symmetry. So here's another, and as time has gone on, she's grown and she's done very well. We haven't corrected the size of her eye yet, but this is possible, and she has not recurred, and this, we have followed her for many, many years. If she does, then we'll deal with it, but the the most important is to improve quality of life. So we've gone from, and here she is much older, and you can see she's grown and she has not recurred. And then what we've discovered, and this is all a learning process, is that if you measure from the midline to the corner on one side, in other words, from here to here on one side, and from there to there, this side of the lip is longer than that. And that's from the overgrowth, from the infiltrating lipoma. So what I've done here is, you can see a small surgical scar. I've removed as much of the lip as the disparity is. So I've measured the distance from one side to the other, and I've taken a small segment of her lip out. And now I know that the corner of the mouth is different from the affected side to the other. So it's very easy for me to come and correct this by closing the corner. And if I do close the corner, she's going to have complete symmetry. Okay, I'm sorry if this is upsetting for some patients, but anyway, so it's an ongoing situation. What we're able to do, do you want me to stop or? Oh, okay. So it's an ongoing learning curve, and by comparing left to right, re-establishing symmetry, we're able to correct it. And you can see her eyes are almost equal. If I close the mouth there, the asymmetry will be better. Those are some of the things we can do. And so this is where she started, and this is where she is today. And with a little nip and tuck over here, I think we're going to be a lot better. So these are some of the things we can do. This particular guy, if you look at his CT scan and you compare the normal side with the abnormal side, you can see the tremendous infiltration of all the tissues, parotid, masseter, buccal fat, and you can see the asymmetry both in bone and in soft tissues, which is created by the lipoma when comparing left with right. And so we did the same thing with him. We removed all of the soft tissues. We reanimated his face, and you can see he's got some movement. Unfortunately, he had been somewhere else, and so the incision that was made was along the middle of the face. I would not have chosen that incision. All the incisions that I've done have been from a facelift direction. And so we've chosen this, and we've been able to reanimate him. And you can see all I need to do now is lift up his lip just slightly and reduce the fullness of the upper and lower lip, and he'll be back to being much more symmetrical. And there he is with full movement. That's where he started, and this is where he will be. So he's not perfectly symmetrical. And remember one thing, if you look at a photograph or in a mirror, you're looking at a flat plane. When we look at each other, we look in dimension. So any slight asymmetry is more obvious in a mirror than it is in real life. And that's what we've seen. So he's done very well. And once again, we have 5 or 6 years follow-up. We've not had any recurrence. Now, that's not to say that it won't recur, but I'm hopeful that alpelisib or one of the other drugs will pan out and be able to prevent recurrence. And it's very important for us to work together to try and prevent this from happening. So what's made the difference is facial reanimation, because we know from the earlier lecture that these nerves are affected. And so we have to remove nerves, we have to remove muscle to prevent recurrence, and in so doing, we can reanimate the face. She was paralyzed before, and you can see she's moving. Now, one side moves faster than the other because remember, the signals traveling from one side to the other, but in real life it's really not noticeable.
And a big smile. Relax. And a big smile. Relax.
Sorry. And here's another patient who had a bad lymphatic malformation, and so reanimation has made a big difference. This patient has facial infiltrating lipoma, and there she was as an older child, and she has had removal and reanimation, and the reanimation is starting to work, and each day it's getting stronger and stronger, and so she's improved tremendously. Here's another patient. So we are able to help these patients, and with facial reanimation, like we have done with vascular anomalies and other conditions, this has added a new dimension to our ability to improve quality of life. It's a long journey. We've got to remove soft tissues, we've got to re-establish facial symmetry, and we have to re-establish facial movement. There's a lot of work, but I think that it's worth it because we can do a lot to help patients. Now, the last frontier in vascular anomalies, sorry, this is a shield over the eye, so don't worry, is to re-establish sensation, and we can do that in the same process. We take a nerve from the normal side, plug it into a sensory nerve, run it across, and we're able to re-establish sensation on the cornea or on the eye, which is very important. That's just a shield to protect the cornea. And so we can do motor and sensory re-innovation by using these techniques, and that's been very successful. I would not be able to do this without Teresa O, who's not here today, but she's the reanimation expert, and together with Teresa, we've been able to help a lot of patients with vascular anomalies and patients with facial infiltrating lipoma. This is an ongoing process. I think your study is very, very important for us to be able to understand. And as I mentioned, as physicians, we need to talk to each other, we need to work together. But more than anything, we need the information from patients like you. We need to know what happens, what's affected, what is good, what is not good. And it's only through collaboration that we can understand how to move forward with this. So getting together as a group of patients and collecting information and supplying this information to us is very helpful. It pushes the ball along the road a little further and a little further until we hopefully will be able to control it. So I'm happy to answer any questions, and I'm sorry I upset the patient, but
we had the same yesterday.
Oh, okay. All right. Okay. But, this is where we are today. You're trying to understand the medical side. I'm trying to understand from the surgical side. We don't have a magic bullet right now, but we do have some way of being able to improve quality of life. So that's pretty much. So I'm happy to answer any questions. Thanks.
Your results are absolutely magnificent, mind-blowing, I think, for many people in many cases. Obviously, there's a very fine line when you should intervene and when not. What's your view on that?
Yeah, so I think that first of all, this is a multidisciplinary situation. We should all sit down with each other as physicians and with the patient and decide when and if to intervene, because that's important. Yeah. And I think that we should intervene if the quality of life of the patient is affected and asymmetry has been disturbed, and we are able as physicians to do something. And remember, it should be a multidisciplinary approach. If I can remove some of the offending tissue which is destroying the symmetry, and then there is some medication that can prevent recurrence of this, then we've won the situation. At the moment, all I can do is remove a lot of tissue and reanimate, but it's a hell of a long journey to go through.
Yeah.
So when to intervene, I think the patient will help us decide that. But the patient needs to understand that this is a long journey. It's not a quick journey. It's not just a simple operation, it's multiple procedures. So I know that the costs in the United States are ridiculous, prohibitive, and so for this reason we've come to Europe to try and help European patients and try and work within your system and to do all we can to help.
So that would be my follow-up question.
Sure.
So let's say that someone here wants to get things rolling.
Right.
What should they do?
Okay, so we did have something established in Germany. Unfortunately, my friend and colleague has passed away, and so we're looking for a place to work. I do have a place in Athens. There is a clinic with Dr. Tombris, who's a phenomenally talented maxillofacial surgeon. He trained in Boston. He's very, very good, very talented, and works with me on vascular anomalies. So at this point in time, I'm able to come to Athens. Dr. O is able to come to Athens, and we can establish something there and get things going. I would love to work somewhere else as well. At this point, I don't have anywhere else, but we can see patients in Athens.
Yeah.
Sure.
You ever seen so many cell patients in one go? I mean, say how many people you've seen today with cell. Have you seen that before?
No. The problem is, as physicians, each physician would only have a minimal experience. We'd see 2 or 3 or 4 or 5 patients. Now, the truth be told, I probably have seen patients in the past who were misdiagnosed and were treated for other conditions. So in retrospect, yes, I've seen more patients, but remember, this is a newly recognized condition. It's always been around, but it's just recently been recognized.
Oh, I know that.
And and you know that better than we do. And so to be able to see so many patients in one room is a unique experience. And I think to be able to collect information, to do research, to understand is what medicine's all about. It's very, very important for you and for us to be able to collaborate and to understand which direction we need to move in, because that's the only way we're going to conquer this. And this is something we need to do. So to gather as much information, to present as much information is very, very important. And as a surgeon, I'm just a technician. You know, surgery is very barbaric. We open things up and chop things out and hope for the best. So there is some talent, there is some, there's an art and a science to surgery, especially plastic surgery, and that's what I try and teach, is the art to it. There is an art, and that's the only way we're going to be able to get on top of this. So I'm happy to entertain any questions, and yeah.
What would be the general time frame for your, which seems like a 3-stage kind of process? Would it be first surgery, then you have to wait 6 to 9 months, and then next, and then
Correct.
a similar time frame?
Exactly. So what we do is, depending on the situation, if a patient presents with a tremendous amount of asymmetry, especially someone who's had multiple procedures and a lot of scar tissue, so we would remove everything to re-establish symmetry. That would include the muscles that move the face, because they're infiltrated, and we've learned from our own experience that if you leave this behind, it's just simply going to grow back. So you have to remove these muscles. So the time frame is surgery, and at the same time, we take a little slip of sural nerve from the leg, plug it into the normal side, run it across, and leave it there for later, for 6 months later. As soon as the nerves have grown in, we then take a small slip of muscle from the leg, bring it across, and reanimate. So that whole process is 6 to 9 months. But it's a soft tissue surgery. There's going to be a hard tissue surgery as well, some bony work, and then reanimation. That's the only way we know how. We don't know. Alpelisib may reduce some of the infiltrated overgrowth, but it's not a magic bullet. It's not going to reestablish. We don't have any magic drug that will get rid of what or undo what has been done. So we have to work that way.
Specifically the medical treatment, there will be a whole session after the break, also very much focused on alpelisib.
Yeah. And remember, you know, there are side effects to drugs. One of the drugs, I became very unpopular and was almost assassinated by, by letting people know that sirolimus can affect the ability of a patient to conceive pregnancy. And this was always known. There are about 20 or 30 papers on this, but it wasn't told to patients. And sure, some women have gotten pregnant. Some male patients have been able to help with the situation, but you know, these drugs do have side effects, so we need to know about them, and we need to inform our patients about them. It's very important. Yes?
Do you think that surgery is the best way of treat FIL?
At this point, yes. Because we don't know how to correct the gene abnormality. We don't know how to re-establish facial symmetry. So at this point, we have nothing else. You know, what else do we have but surgery combined with medicine? If we had a drug, I would happily step back and use it. If we had something that could, we're here to help our patients. Our job is to help our patients and to re-establish function of life. And at this point, all we have is surgery. Yeah.
How is it with bone overgrowth? For example, by me, which surgical options is used? Okay,
so you have thickness of your lip and you have a lot of bone overgrowth. So I'd have to see what your MRI and your CT look like, and by combining these I'd be able to correct the overgrowth. I work with a very talented maxillofacial surgeon, and between him and I'm sure we can correct this. Yeah.
After the surgery,
yes,
it's possible that grow again.
Okay, so I can't guarantee anything. However, we have the experience now of 2 patients in whom we've had long-term follow-up, and neither have regrown. Okay? And so this is very, very hopeful. And if there is some regrowth, it doesn't mean we can't do anything about it. Do you understand?
Yeah.
So all I can say is, yes, right now I can re-establish symmetry and I can restore movement, and we'll see what happens in the future. We have the promise of alpelisib, we have the promise of new drugs which are being developed, and maybe one day in 20 or 30 years somebody will be able to fix this PIK3CA gene and stop the process.
Thank
Okay, thank you very much.
So with that, let's thank Dr. Waner again.
Thank you.